It's summer in EMS. You've got your toes in the water, ass in the sand, not a worry in the world, a cold beer in your hand. EMS life is good today. And it's with that hashtag thinking drives behavior thought in mind that there's never been a better time to amp up the EMS CQI detective and deductive reasoning part of your brain and engage in a topic that stands at the very heart of quality patient care. And that is objective EMS CQI auditing. Hello, everyone. I am Kevin Kelly. He's Paul Gerard. We are Gerard & Associates, your national EMS CQI consulting firm. Check us out at the website, www.gerardassociates.com. You're listening to the G&A Way EMS CQI podcast. We're on Podbean, Apple Podcasts, Spotify, Tubla, all of those. We're grateful that you have tuned in. Today, we're thrilled to introduce Jerry Bardwell, a true New England EMS legend with over 40 years of EMS clinical, education, management, leadership, and CQI auditing experience. Jerry's career spans the private sector, fire departments, military service, and hospital-based EMS, making him a seasoned pro in every area of emergency medical services. From crew chief to director, Jerry has held key EMS positions throughout Vermont, New Hampshire, Rhode Island, in Massachusetts, where he's been based since 1995. In 2006, Jerry joined Gerard & Associates as a QI auditor and quickly rose to the role of operations manager. His insights have been published in several EMS periodicals, and he's lent his expertise as an editorial reviewer for major medical textbooks used by first responders, EMTs, and paramedic students. Currently, Jerry serves on an EMS advisory board for a major pharmaceutical company tackling the opioid crisis. His mantra for quality assurance and improvement is, what you do that's good, we help you do better. Jerry, hello. It's great to see you and great to have you on the show.
Hello, and thank you for having me. I'm excited to be here.
How was that introduction? Was that true, accurate, and to the point?
At least for today.
Okay. Hey, so, and Paul, I mean, since you own the joint, good to see you as well.
Yeah, thanks. I'm the third wheel today, I guess, right? So, yeah, great to be here. Glad to have Jerry on. Jerry's one of the very valuable members of the G&A Way team, and he's my ops manager, does a great job. He's principally involved in hiring and training our auditors. So I thought it'd be a great idea to have him come on and talk about auditing a call, because it's one of the questions we get from time to time from people who listen to the podcast. We'll get, email correspondence or phone calls, and people will talk about, how do you come up with this stuff? So that's where I think Jerry can help. I think Jerry can talk to how he trains our folks and what types of things auditors should be looking for and paying attention to. So if you're doing in-house CQI and you want to know how to be a really good run report auditor to elicit the info that's critical to your CQI process, Jerry's going to help you out.
So shall we kick this off, Paul?
Let's do it.
All right. So I'll kick it out to you gentlemen. Why is the audit of the patient care report so important?
Well, a number of facets. One is to assure that the patient has received the proper care, the proper assessment, the proper care in a timely manner, and that it's according to the state regulations or protocols. And the other is to assure that the provider understands what was going on at the time, and that they have a better grasp of what it is that they could have done differently that might have been better, or from our standpoint, if we see something where the provider is going in a direction that we didn't think was quite right, to get them back on track. So the audit helps in that way. It also helps the service overall by identifying that where are the problematic areas, what areas are there that we need to identify, that we need to perhaps train or retrain all of our providers. Maybe we identified a trend, for example. A lot of what we see is the lack of serial vital signs as part of an assessment. And that's one of the things that we pick up on, and we track that. And then when we talk to the EMS directors, training coordinators for the various agencies. We bring that data to them and say, we're seeing a trend here where your providers aren't tracking serial vital signs. The standard is that you take a set upon a patient contact, you take a set upon patient arrival at the hospital, and maybe somewhere in between all of that. Yeah. But there should be at least 2 sets of vital signs, and we're not seeing that. And this is why you need to do this. You have the national standard of training that says that you should be doing this. So we bring that forward, and they in turn will say, okay, you know what, we're going to run a training session on the assessment of vital signs and how that works and how it applies into good patient assessment. So that's one area. If we identify trends where we're seeing improper assessment or treatment across the board that could have adverse outcomes to the patient, then it's our job to identify it quickly, bring it forward quickly to the various agencies, and let them know that we're seeing this. Our job is not to discipline. It's not to beat people over the head, and we're not here to pull licenses and everything. Our job is to identify what is a problem or could be a problem just by looking at the run report. And, go ahead.
Yeah. So it sounds like at its core, and really what I want the audience to know about is why is the Gerard and Associates, why is our auditing process so much more encompassing and advanced than the traditional pedantic EMS CQI programs that we see out there? I mean, what's the key ingredient that our auditors that makes our auditors so honed in on finding the in the weeds stuff that makes us different than say other EMS CQI programs?
The simple answer is that most EMS services don't have a good comprehensive CQI process. And if they do, it's usually based on, did they get the name, address, date of birth, insurance information so that we can bill? And some CQI or some internal CQI processes that happen. When I've talked to people that we're going to hire and ask them about their background, do you have CQI experience? I've done some. Okay, what did that entail? Well, I've looked for IVs, endotracheal intubations and that type of thing. And that's bean counting. That's not really looking at the comprehensive component of it. We, on the other hand, we train our staff to look at a patient care report and to disassemble it like a jigsaw puzzle and put it back together. There are 3 questions that we as CQI auditors have to get answers for. What did they do? When did they do it? And was it the right thing to do? And so by taking those 3 questions and then disassembling that patient care report, do the times of the call match the times that are noted in the procedures section and the vitals section? And do they match to the narrative? And we have to piece all of that together and look between the lines. We have to read between the lines to get a better understanding of what it is that the provider was seeing, hearing, and feeling at that time.
You're putting yourself as the auditor in the shoes of that provider at the time they were providing the patient care to the extent possible, and then trying to visualize that, recreate that in your head, and then from there develop your baseline questions as to how to get the information that you're looking for. What should have been done? Was it the right thing to do? All of that. Is that the gist of it, Paul?
No, well, it is. Yeah, it is. But I want to add another point is what makes us, I think, significantly different from most CQI programs is that we don't train our auditors when auditing the report simply to look for errors. We don't ask them to just find where the provider messed up something clinically.
Right.
We ask them to identify anything in the report that is an opportunity for improvement. So there's a big distinction there, right? If you're just looking for the major screw-ups, then you're waiting for bad things to happen. You then find them. And the reason that providers get so frustrated with the CQI process is they feel that the only time they hear from the CQI guys is when they're being given hell for something.
Right.
So they got to get used to the fact that there's a feedback mechanism back and forth on these calls to determine what happened, and that in a lot of cases, everything will be fine. We just want to verify and confirm. So the auditors are trained to identify areas for improvement, not necessarily errors. And because of that, they screen in a whole bunch of really good, valuable, useful CQI material that our CQI coordinators can then use when they go back and talk to the provider about the call. And it can be anything from minor documentation discrepancies so that we can impart upon them the importance of accuracy in documentation. So it might sound trivial when they put that the patient's 18 in the patient's age section and they put 17 in the narrative. It might sound trivial. And we talked about this before, Kevin, as this particular example, where it's not trivial if the patient signed a patient refusal, for example, and they can't legally do that. So if the run report has lots of those little errors, and you know as a lawyer, little errors can trip you up significantly in a court of law or during an EMS investigation. So our auditors are really looking for anything that they can identify and put into their audit notes that could be potentially improved upon by the provider next time they do that type of call, both in terms of documentation and patient care. And then our coordinators discuss those cases, every single one of them, with the provider. We don't just wait for the bad stuff to happen.
And in conjunction with that, Kevin, we also look to find what is it that they did right and bring that forward. You know, it's like you did great job here, good use of end title, good thinking, calling medical control on this. So it's not always the bad. It's also looking for the good of it. And when I walk into a service and doesn't necessarily mean I'm there for to nail somebody. As I tell them, look, just because I walk through the door, it doesn't mean I bring bad news. Sometimes I'm here just to personally give you a pat on the back, say, well done. This is how you do it.
When we walk in the door, sometimes people are actually eager to see us. Walk in, like, oh, you here to talk to me? No, I'm here to talk to somebody else. And they're actually a little bit disappointed because they enjoy the conversations, because they know the conversation isn't, you screwed this up yesterday and we need to talk about it. The discussions range into all different areas, including the nice job on that call stuff. So the importance of the auditor picking up the good stuff. And sometimes, and Jerry knows this, sometimes you can have a category 4 call, which for us is a high probability of an adverse patient outcome. That's kind of the worst score you can get kind of thing. And a kudos on the same call. So you didn't defibrillate the guy in, the first few seconds of arrival at the patient's side for that VFib. So that's a problem. However, you did an awesome job on the intubation. So kudos on the intubation. The airway management was superior. But you forgot to defibrillate them quickly. So we have both of those conversations at the same time, which can be a little disconcerting for folks at first because they're like, are you here to yell at me or give me a pat on the back? Well, we're here to kind of, I don't want to say do both because we don't really yell at people, but, we're here to present the whole case to you, good, bad, whatever. So we're not just waiting for the bad stuff. If there's a good reason to give them that pat on the back, it should be given as well.
It's an art and a science, right? The art and science of QI. So what would you guys say makes for a good EMS CQI auditor? What kind of, and we have our 4 C's, the GNA 4 C's, but specific to the art and science of culling information out of that patient care report to be used positively to coach up the EMT or the paramedic. What traits are you looking for in your auditors to call that information out, to be that detective, that deductive reasoner?
Somebody who has an open mind and is open to new ideas. That's the type of person that we want. And I'll simplify that by saying that over the years that we've hired staff here, I take them through the training process, which is 12 hours, thereabouts, of how to look at a report. And to the person. Every single person I've ever trained to be part of our staff have said the same thing. I don't write my reports the same way I used to. And the prime reason is because now I know somebody is looking at them. So that's the kind of person we want. Somebody who is open-minded and is willing to, kind of shift gears. I mean, over the past 40 years, I have had my way of writing a patient care report up until about 2006 when I first started here. And I find myself now adding even minute details, because even though it may be weeks, months before somebody actually reads that report, somebody is going to read that report.
Right.
Somewhere down the line. So something as simple as changing the way that you approach, even in your own profession, how you write that report. And so a staff member that we hire on here, everybody has changed their thinking, and it gives them another dimension to look at. As you alluded to, looking through it of the eyes of the provider. And one of the things I hear is, well, you know what, Jerry, you weren't there. I get it. I understand it. But you need to put me there, and the only way that you can put me there is through that report.
I'm gonna add something to that. I'm gonna add that a good auditor, one of the skills and traits that we look for in a good auditor is good writing skills, good writing ability, and so we have to kind of retrain auditors to not write like they're writing a narrative a little bit, because we don't want them to write in an accusatory tone, because when we present, the coordinators present that back to the providers, they get offended a lot of times based on the language and the tone of the auditor and the medical director. Sometimes we have to go back to medical directors and tell them, stop saying that. We had one great medical director, a fantastic guy. And when he talks to you, everybody loves him. When he talks verbally, one of his catchphrases is, "What were you thinking?" So in the middle of rounds, he can say, "So Kevin, on that call yesterday, what were you thinking?" And you don't take offense to that. But when I approach you as a CQI coordinator and say, here's the doctor's medical directors, he's saying, what were you thinking? This patient should have been ALS'd. They get defensive. And you can't have good QA if your providers are feeling defensive or feeling like they got to protect their interest, as opposed to having good, honest conversation. That starts with good written notes from the auditor. So we often have to train them how to do that. And it's part of our in-house CQI process. We have a senior auditor who reviews run reports, and they'll forward their results of their review. And when we go back to the providers and talk to the auditors and talk to them, we oftentimes will give them recommendations for how to change their language so it doesn't sound offensive. It doesn't sound, they're not trying to be. It just can come across that way in written form.
Yeah, absolutely right. I mean, we've all post-COVID gotten, I think, a bit more sensitive, and having these courageous conversations that, for all intent and purposes, are authentic and are humanistic on the receiver, that sender message receiver paradigm of communication. Well, right. That gets discombobulated and people get pissed off. They get pissed off. They get butthurt. And then everything else falls into negativity. Bingo. The schedule being held over on your shift. You shut down, you tunnel visioned. Right. All of that. So, we've often, a couple of points, listening to you guys talk about this. Paul and I have talked about days at St. Luke's where you hand wrote the run report and you left it on a box on the table and everybody read your run report. Right. And if you, made mistakes, perhaps it wasn't as dealt with as with the sensitivity that it's dealt with. You got hazed, you got, your balls broken, all right. in good fun, but you got to be. Sometimes, right. But yeah, I mean, it's not what you do, it's how you do it. And having somebody reading every single run report that you generate, that's going to change your behavior. You're going to want to show off and be that competitive spirit and be that kick-ass documenter and assessor. And that comes with the knowledge that somebody gives a crap about what you do and how you do it, and that's EMS CQI.
Yeah. To get back to your question, though, before we move on, Kevin, is the traits. There's actually quite a few of them, but one of the other traits that we look for is oftentimes, I personally prefer to hire, as an auditor, somebody who's an educator, who has education on their resume, as opposed to CQI person on their resume. And the reason is, generically in EMS, CQI is not always done the way it should be, in my opinion, and in the opinion of GNA, I guess. And so they're looking for those errors, and they're hypercritical. So when we hire somebody with a CQI background, they bring those negative traits to the process, and we have to get them to stop looking at things that way, which is hard. When you hire an educator to be an auditor, those folks are all about teaching. So they generally will construct their comments in an educative fashion. They sometimes will add stuff like, hey, there's a really good article on this topic on blah, 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 which we can use. Mm-hmm. So their mindset is different from a traditional EMS CQI person. And so in my opinion, and Jerry, you might agree or disagree with this, but I prefer to hire educators than experienced EMS CQI folks to use through GNA as a GNA employee. Do you agree with that, Jerry? Or do you find something different?
I've gone, either way. Educators are probably the prime focus, based on, as Paul said, based on the way that they present reviews, for lack of a better term. I won't call it a criticism because that's not what it is. But they do tend to put it into a teaching format. And there have been the last several new staff that we've got several on there that are educators, and you can look at their commentaries and you can see the difference, the teacher coming through. Be sure to include this and make sure that you do that. It's a good idea to include, whatever the information might be. And it actually softens the conversation with the provider. So when you walk in and you're like, I bet you're here to see me about that call I did the other day. Yeah, but let's take a look at it and let's see what we found, and we'll go from there. And then when they read the comments, they're like, oh yeah, I see it, I understand it. Okay, that makes sense. I should have done this, and yeah, you're right. I should have put the end title on it. So it does soften the conversation, and you get a lot more headway with the provider, through that. Whereas opposed to, you come off, 6 guns blazing from the hip, they're gonna fire back, and one of the things, as trivial as it sounds, something as simple as Paul said, you need somebody who has a good command of writing, the English language. And so one of the pushbacks I hear is that, yeah, you know what, you guys, you're coming in here and you're banging on me because I didn't even give aspirin to the chest pain patient, but your auditor can't spell aspirin. Look at this. He spells it ASS.
Right.
So that's a defense mechanism. That's what they do. They got to find a way to.
It discredits the CQI process a little bit.
Yeah. So as far as our staff are concerned, we have a number of different mechanisms in place in which we try to assure that the auditors are presenting it in such a way that it is not accusatory. As I tell them, stay away from the pronouns. You, me, I, they, we, us. You got to stay away from those. I think you should have is probably the worst thing you can start any review out on. Or you should have done this.
Right. Comes across as
because
negative.
That's immediately, it's going to be, sit back, arms folded, and a shutdown.
Yeah, this compliance, this CQI program has always been education-based versus compliance-based, and that's a huge word choice difference. When you think of education or you think of teacher, that that comes to mind a certain image versus, say, compliance officer.
Right.
So, in fact, we are an education-based EMS CQI program.
Mm-hmm. Correct.
Exactly.
Right. Our coordinators, when they go and talk to individuals, will oftentimes bring reference material, bring articles, website references,
right.
The protocol sometimes, which is obvious. But I used to have a thick folder, all photocopies of the difference between SVT and VTAC and how to tell the difference.
Yeah.
So if we dealt with that call, we're having that discussion. I got something for you to read, and you can hand that as a handout to read, which is, you have the discussion too. But it's a little less threatening to say, hey, this might interest you. Why don't you, check this article out? So it starts with the auditor, and the auditor has an education background, and they in their notes reference that sort of material. It goes down a lot easier.
Hey, how difficult would it be for you guys to boot up a run report and show the audience how you go through it, what you do, your detective work? Is that possible?
Yep, absolutely. So somebody's trying to move my mouse.
That's
complicated,
moving your mouse.
Yeah. All right. So let's take a look at this this case here. This is a typical EPCR that we see, and when I open a report it doesn't matter what the report is. When I open it, I do a quick scan. I'm looking for what is the issue here? Why is it that ambulance rolled? And I'm looking for things like the chief complaint. In this case, it's an abdominal pain. And I'll look at things like, is the gender filled out? Do we have the patient's age? Do we have such things as PMH meds and allergies? PMH meds, allergies, missing EKGs, missing GCS scores, and missing values for blood sugars and or end tidal are the top 7 documentation errors that we see here at GNA when we audit a report. The other things, little things here and there, they fall behind, but those are the top 7 documentation errors that we see. So when I scan a report, I'm looking for, did they do PMH meds and allergies? And I see, yes, there is information in there. Did they do vital signs? Yes, they did. There is a set of vital signs. Keep that earlier thing that I told you about. What is the standard? Standard says at least 2 sets of vital signs.
And then if you're on scene longer, the other thing we're looking for, and it's enshrined in many protocols, is you have either the 5 or 15-minute rule. So if they're unstable every 5 minutes, if they're stable every 15 minutes. So we're looking for a first in, a last out. If you had a 2-minute on scene time and a 3-minute transport time, that might be all you can get. But beyond that, are they meeting those other standards? And then the other question becomes, and this is a question that Jerry can probably answer, is a lot of times people will ask, well, what constitutes a proper documentation of a full set of vital signs? So sometimes the auditors will see 4 sets of vitals. They have 1 respiratory rate originally at the first set, 1 respiratory rate at the end, but no respiratory rates documented for the other sets of vital signs. And the question is that adequate? So, Jerry, how do you train our auditors on that? Or what types of comments or advice can you give on that?
If we're looking at 7 blood pressures and 7 pulse rates and only 1 respiratory rate, then we have to call it out. Mm-hmm. If you're going to take vital signs, you take vital signs.
Yeah.
And, the vital signs are blood pressure, pulse, respirations, SpO2, end tidal if applicable, and GCS scores, RTS score if that's applicable. So these are the things that encompass vital signs. So if you're going to take a blood pressure and a pulse, it stands to reason that you probably ought to look at that respiratory rate as well and put a number in there.
Yeah.
And looking at this, go ahead.
So some medical directors want to also see as part of their vitals package SpO2s, and if end tidal is going to be used, end tidal, and they'll consider it incomplete vitals documentation if they don't have, for example, an end tidal or a SAT. How do we train our auditor? Because that varies medical director to medical director, and even textbook to textbook. Some people say a SAT is part of your vitals package. Others say no, blood pressure, pulse, respiratory rate. What do we advise auditors on in regard to that?
I tell them to look at the report and look at how the patient presents.
Yep.
Because that's going to tell you a lot of things. In looking at a if I had a patient with a simple hand laceration, is the SpO2 going to be a critical factor in this?
Right.
Probably not.
Right.
It's probably not a deep concern, but the SpO2 is one of those things that you kind of do automatically. Mm-hmm. It's like the blood sugar. When folks do an IV, they'll automatically get a blood sugar as a matter of course, and that's fine. Even if they didn't need it, but they do it, and that's perfectly okay. But if they didn't do a blood sugar, and I'm looking at the report and say to myself, well, it really didn't warrant a blood sugar. Blood sugar doesn't seem to be the key component here. Then I'll probably let it go. But if it's a critical piece of information, the SpO2 could be considered a critical piece of information, just like the 12 lead. Yeah. Then that might involve a high infraction score. It could be as high as of a 4 if we don't have that information.
See, that's the beauty of the scoring system, right? So we review the audit, isolate all the issues, but then we also score the call based on our 0 through 4 scoring index. So a 0 is everything's fine, do it again next time. A 1 means that the care is appropriate, but there's documentation elements that can be improved upon, and then our auditors isolate those. And then a 2, 3, or 4 is a low, medium, or high risk of a potential adverse patient outcome. So you can have somebody who didn't document a blood sugar, and it could be simply a 1 because it's semi-relevant in this case. Should have gotten one, but it's not a big deal from a clinical perspective. Or it could be a 4 because this is a patient with a history of diabetes who's unaltered or unconscious, and you didn't do a blood sugar on them. So
exactly.
So it puts it into perspective. It's not just a did you do it or didn't you do it, using the scoring system. And the docs do this a lot. I really want you to ALS this patient, but I'm downgrading it to a 2. So that tells you they want you to do it. You got to do it, but they don't think it's a critical fail type of thing.
Right. So in looking at this report, we see one set of vital signs. Now, some folks will look at this and will say, oh, 120/86, heart rate's 90, respirations are okay, SpO2 is 99, this patient's stable. How do you know that? And the answer is we don't, because there's nothing to compare it to. This patient could have gone from 120 on 86 down to 50 on 0, in a space of just a few minutes. So this is one of the things that we look at. The other thing that we look at is what's the extent of the assessment. Now, in this particular EMS report, we have what we call the assessments checklist, and some services use it okay. That's probably the best term I'm going to come up with. Most don't use it correctly at all, and that's a bit problematic. So when they don't use this, if they leave things missing, like lung sounds are not assessed, or the whatever the case may be relevant to the case, that could be problematic. The other thing is that it can be loaded with contradictions. They might say that the lung sounds had bilateral wheezing up in here, but then you get down in the narrative and it'll say the lung sounds were clear.
Right.
Yeah.
So it can be a contradiction.
Yeah. This is a big area from an audit perspective where you're going to find a lot of errors because you have that contradiction. And then the question becomes, well, which was it? Because one might be actionable from a patient care standpoint and the other may not. So when you're auditing your run reports, as doing your in-house CQI for folks who are doing that, that's an area where you probably want to spend some time. A lot of times we also see that providers will just leave it. They'll pick not assessed because that's the generic for each of those fields, the default, I guess, for each of those fields. So in those checkbox, that list, it'll say lung sounds not assessed, cardiovascular not assessed, neuro not assessed, and then they put everything in their narrative. Well, again, as a lawyer, Kevin, what are you going to pick up on when you're trying to prosecute that call, that they didn't assess the patient adequately because it says they didn't, or the narrative where it says they did do some of that stuff?
Exactly. Well, it depends who's paying me. That's basically which, where you stand depends upon where you sit. So, are you the plaintiff or are you the defense lawyer? But I got to say, the inconsistent inconsistencies in EMS run reports, medical documentation, police reports, whatever, is a treasure trove for a lawyer on cross to make you look like a friggin' moron.
Right.
And that's basically it, is to make the finder of fact, whether it's a judge in a bench trial or more often than not, it's going to be a jury in a jury trial, cast doubt on your ability to adequately care for the patient. And inconsistencies in documentation, that's low hanging fruit.
Right.
I mean, that's first year law school stuff. But there's an ever-increasing concentric circle from missing and normalization of deviance on the small stuff that leads to bigger problems that actually harm people and create significant liability for paramedics and the agencies.
Correct.
In looking at this report, one of the key components I look at are the times. And in this case here, we see that the ambulance was on scene. This is a interfacility transfer. This was a patient going from one hospital to another for a surgical consult. We look at the times, and we note that they got on scene at 22:10, but they don't make patient contact till 22:35. So then it's like I'm looking at the narrative. Why is there a 25-minute delay in getting to your patient? Granted, it is a transfer, but why did it take 25 minutes to make patient contact? What happened? And that part should be documented here, particularly if it's a 911 call. Right. If I look at a 911 call and I see that kind of a time span between when the ambulance arrived on scene and then when they actually make patient contact, I'm looking for why.
Hostage standoff, right? That's what you're looking for. There's got to be a standoff. You're on the news looking at all of that stuff.
Yeah. There's active shooter.
There's a half a mile into,
right.
He's a half a mile down there, or he's over a cliff.
Yeah.
Right.
Something of that nature.
We'll let the bomb squad clear the scene before we go in.
Yeah. Scene wasn't safe.
Right.
But and then I look at the narrative, and I have a saying when I teach documentation classes, that the unwritten word does not lie to me. And I put that in there because we've been taught since the days of Johnny and Roy that you didn't write it down, you didn't do it. And Jordan Associates took that statement and spun it a little bit and expanded on it to, you didn't write it down, you didn't do it. You didn't do it, you didn't catch it. You didn't catch it, you didn't treat it. And so when I look at a report and I see all these things being listed here, but I'm reading between the lines, like, wait a minute, where's the collar? And I've had providers arguing with me all day long. I put the collar on, Jerry. I know I put the collar on. Look, it's not that I don't believe you, but the fact of the matter is it's not here. It's not listed. It's not anywhere. It's not in your procedure section. It's not in the assessments. It's not even in your narrative. When did you put the collar on? The unwritten word does not lie to me. Therefore, you have to assume that it wasn't done. We're not saying we don't believe them.
Yeah.
But we have to impress upon them that until you write it down and you make it as fact, we have to take it at face value.
No question.
So, yeah.
Yeah. But also to take that one step further, you're going to argue that I'm going to get the video footage, the security footage of the paramedics wheeling in the patient on the stretcher with the collar on. Now, granted, it's a crummy thing not to document, but the other point is, and Paul and I talk about it almost every show, cameras out there are ubiquitous, and even the dumbest defense lawyer is going to canvass to get that video footage to attempt to find exculpatory evidence. And that's, I didn't write that I put the collar on, but I did put the collar on, and there's evidence of that. It's going to be in the medical record, the nursing notes, probably, that the patient came in with the collar on as well. But
could very well be right.
But absolutely, that is an absolute true statement. That if it wasn't documented, it for all intent and purposes, it wasn't done until it's proven it was.
Right. And in this case here, remember we said we had a set of vital signs up in here. Now, in this case here, whoever reviewed this report before it came to us caught it, because you look here and you note that there's an addendum, and it was written, some 12 hours after this call was terminated, but repeat vitals provided, arrival to Gerardville Hospital, and they list them out. Okay, I'm glad they did that, but it also bears out the fact that this needs to be brought to the attention of the provider, that this is something that you should have done up in here. And on top of that, given the amount of contact time you have with that patient, you actually should have had a third set of vital signs in here. So these are things that we look at and try to piece together when we look at a report. If I could show you another one real quick, this is probably the classic report that this came through some years back, but this was an actual report. We changed the names, and you look at this and you see propofol and Vanco, and we know right off when we see that this patient is on a vent. And we go up here, and sure enough, there's the vent, and there's the O2 and the vital signs. There they are. They're serial vital signs right down the line. But what caught the attention of the auditor, I'm going to blow this up just so there is no mistake in this at all. This is what we had for a narrative. That was it.
That was it, huh?
That was it. Three words.
I take it by your reaction, you're not satisfied with that?
It went well.
Well, the first question out of my mouth was, well, how do you know it didn't go bad?
What would they have written if it did go bad?
That's an interesting, but so this report, this is something that OEMS would crawl all over. Lawyers would have a field day with this.
Absolutely. You don't want to see this sentence on medical documentation or on some statement after your honeymoon night. That's not appropriate.
Yeah. So these are the types of things that we see here at Gerard and Associates. It's just a simple sample. We've got whenever we get applicants in for the position of auditor, there's a process that they go through, and one of them is that they've got to review 3 patient care reports, and they've got to write a review, and they have instructions on how to do that. And so I get those reports back, and part of the interview process is that it gets reviewed with them. Let's go through it. Let's see what you found, and let's see what maybe you should have picked up on. And by and large, I think most of our applicants have done a pretty good job, but there have been times when folks will just quickly skim a report and they'll write, respirations are missing, and this should have been done, and that should have been done. Okay. Did you pick up on the fact that when they made contact with the patient, that the blood pressure was 50 on 0 and the heart rate was in the 30s? And if you look up in the procedure section, what should have been there that they didn't do? And they'll think about it, and it's the pads. Maybe they should put pads on. So, and then they think about it. It's like, oh, geez, how did I miss that? And it's because a lot of folks don't have that kind of in-depth focus of when they're looking at a patient care report, and that's our job to teach them. So when they come to us and they apply to us, we put them through this 12-hour process, and that's why I say the database is simplistically complex. That's filling in a box, a drop-down menu, and writing a few lines of, patient had chest pain, probably should have considered aspirin. That's the simple part. The hard part is looking at that report. And I think that's the biggest issue I have with applicants, prospective applicants, is getting to understand this stuff is not easy. It is not easy to look at this in more ways than one, but to be able to dissect it, piece it together, and make it fit to see what did they do, when did they do it, and was it the right thing to do? And if it fits, then you've got a good audit, and then you've got a good provider who did the right thing at the right time. And if it doesn't fit, then we need to fix that. And so from here, it goes to the QA coordinators and so on up the line to re-educate these folks out there in the fields.
And a
fix this problem.
A good auditor has the ability to read that information quickly, assimilate and isolate what the issues are, and then provide written documents of the issues that they've identified quickly. Because if you spend an hour on a run report doing this stuff, it's going to take forever, and you're never going to get any work done. So
right.
An auditor has to have, and we've hired auditors who are fantastic providers, have a 6-page resume, all sorts of training. Some of them are PAs or nurses in addition to being paramedics. And it doesn't matter. Some of them still can't process the calls quickly enough to make it worth their while to work as an auditor because they're too analytical. They're hyper analytical. So part of Jerry's training is how to be efficient at reviewing and data entry so you can get through these things in a timely fashion, but still identify the critical issues. So that's, again, one of the traits is that they need to be able to assimilate large volumes of data quickly in determining what might be wrong with the call.
Well, for too long, EMS CQI has been one of those, we got to do it. It's like compliance, check the box.
Yeah.
There wasn't a lot of thought into the art and science of it. How do we improve the whole process? Is there a leadership amalgam to this that we can employ to teach, coach, and mentor? And nobody has, other than, looking at it like a bean counter, like an abacus wearing, pocket protecting, pencil eraser kind of, auditor, accountant kind of thing. And that's not it. No. There's risk management, there's medical legal, there's clinical, there's a whole body of subspecialty that goes into the specialty of being an EMS CQI auditor. And it's why now we're just starting to see how important EMS CQI is to the overall functioning of the EMS agency. And those organizations that invest in EMS CQI, it's going to pay dividends. If you don't, well, if you always do what you always, what's the old saying? If you always do what you always did, you always get what you always got or something, whatever that is. But that's it. And that's I think the ultimate difference in what we do here in GNA. It's just this whole ever increasing concentric circle. It's not just a check the box. Do they have something in the field? Mm-hmm. Yeah. Yes. Okay. Right. Is it the right thing? Right. Yeah, that's the whole other. Yeah. It's now go ahead.
I just wanted, because I know we're running up against time here, and I just want to get one more important point as far as critical skills for an auditor, is that auditors need to, Jerry alluded to it a little bit earlier, but I want to put a fine point on it, is that they need to remain objective, unbiased, and question their audits, right? So we train our auditors not to give their opinion about whether they would have ALS this patient or not, or done a 12-lead, or done a blood sugar. We're asking them to look at this call and say, could the argument be made that you should have done it? And if so, if a reasonably prudent argument. So sometimes we want them to leave at the door their personal preferences in a lot of cases, because that brings their bias into the picture, right? Oh, I wouldn't ALS this guy either. Well, we're not asking if you would ALS a guy. We're asking if it meets protocol, if it meets the standard training for a paramedic or an EMT, whether it meets their medical director's precepts. Does that particular medical director want them to do it? And so a lot of times our auditors will say, hey, Paul, I wouldn't have ALS this patient either, but some medical directors would want it. So we want them to score it at the higher level, right? A 2, 3, or 4, because they should have. It's not the auditor's opinion. So if you're, again, doing in-house CQI auditing, don't look at this as your opinion is this patient didn't need ALS. The question is, could somebody reasonably say this patient should have received ALS because of their clinical condition? And if the answer is yes, let the CQI process vet that question to make the ultimate determination. For us, that means sending it to the medical director and then sending it to the CQI officer, both who coordinator, who are both have their own opinions, and then eliciting the info you need from the provider to make a fair and accurate determination as to which way they should have gone on that call. So stay objective. Get rid of as much of the subjectivity as you can through the process by questioning everything that should be questioned, and let the rest of your CQI process come out with the answer. So a good auditor does that and doesn't just say, I think you should have ALS them because I would have ALS them.
It's probably the hardest facet of this job is to be objective in a very subjective setting.
Right.
We're armchair quarterbacking it, and we know it. But by as Paul said, not injecting our own personal biases into that, then we get a good auditor. And I'll just put a little cherry on it and saying that, to the EMS world, look at if you are looking for a good QA process, if you think your own in-house QA process is adequate and is doing a good job, then fine. But if you really want to get a good, comprehensive QA process, then consider going to an outside source, because we have no biases. We look everything to the same scope.
And our auditors are trained. They are not allowed to audit for agencies that they've worked in previously, or that they know the providers. So we keep it as objective as possible. And so what that does is it allows the auditor on every single call to say, perhaps you should ALS this guy. It doesn't become, well, I worked with Kevin. He's a good medic. If the guy needed ALS, he would have provided it. So I'm pretty sure there's good reasons for why he didn't. So I'm going to let it slide. Our auditors treat every call the same way. Ask the questions that should be asked, jot them down in your notes, and let somebody else further down the CQI line figure out if there's an issue there or not that needs to be corrected or not. So, and again, that's a major difference compared to most auditing programs and most EMS CQI programs.
One of the best pieces of advice I ever got from a paramedic who's long since retired, and he had done QA before, is screw everybody equally. And
you can only say that
right.
in EMS.
Yeah, I can see that.
So we're equal opportunity screwers, I guess.
Well, that's the
message we want to get out there to the public. Thanks, Jerry.
That's why he's your operations manager and not your director of marketing. Right. So did we cover what y'all wanted to cover with this? We're getting close to the hour mark here.
Yeah, I think I did. Jerry, any final thoughts?
No.
Yeah, you sure? You seem kind of non-committal on that one. You got a final thought? Say it, damn it!
Spit it out.
Well, I would just say that to those that are listening, is that if you think you've got what it takes to be a part of our team, and it can be open-minded and subject to new ideas, and you're looking to broaden your horizons, give us a call. Go to our website. Someday there will be, join our team tab in our website, I think.
Right.
But, send us a resume, and we'll take a look at you. There's
a contact us page on the website, and they can send information. They can say, hey, I'm interested in working with you guys, and that'll start the conversation. We can say, sure, send us a resume and that sort of thing. So by all means, or if you just want to kind of wrap things up here, if you just want to talk to any one of us, or in particular Jerry, since he's the star of today's show, and you want to know more about auditing a call, and you have questions or comments or whatnot, you can reach any of us through our website. Jerry's email is jerry.bardwell@gerardassociates.com. Again, I'm paul.gerard@gerardassociates.com. And Kevin's got his own separate legal email that does not end in a gerardassociates.com.
Now, you can call me anytime. I'll forward you to Jerry and Paul.
Right.
I can't. I'll forward
the
you
guys
to
who know. The guys who know the answers, the real answers.
Exactly.
You were referred by who?
Yeah, I'm just a podcast co-host. That's all.
Right.
All right. That do it, folks. You happy?
That's it. I'm happy.
Thank you.
All right.
Thank you for having me this afternoon. It's been a pleasure. I've enjoyed this, playing with this high-tech equipment and talking with you folks. It's been a pleasure.
All right. It was great having you. This is going to wrap up this episode of the G&A Way EMS CQI podcast. We hope you gain valuable insights into the crucial role of objective EMS CQI audits and their impact on pre-hospital patient care. Remember, an objective EMS CQI audit is more than just a procedural necessity. It's a vital practice that ensures consistent, high-quality patient care, reduces risk, and ultimately saves lives. A big thank you to our special guest, Jerry Bardwell, for sharing his extensive knowledge and experience with us today. Jerry's dedication to continuous quality improvement is truly inspiring, and his mantra, "What you do that's good, we help you do better," resonates deeply with our mission here at Gerard & Associates. We encourage you to visit our website at www.gerardassociates.com for more resources and information on EMS CQI. Don't forget to subscribe to our podcast on Podbean, Apple Podcasts, and all the other major platforms so you never miss an episode. Stay safe, stay tuned, stay engaged. Let's continue making a difference in EMS together.
Thanks for listening, everyone.
On 5.